Arthritis is the last thing we'll talk about today, and arthritis is the end of the game. That, the shoulder is shot, and I'll show you how we treat that. And now talking to you about rotator cuff tears. So this is a little picture. This is our friend the supraspinatus tendon, and it's torn right there. And when that tendon detaches off the bone and it starts to retract, that's a rotator cuff tear. And that can happen because that bone spur over time digs in. But I don't operate on people prophylactically. I don't pull people off the street and get rid of their bone spurs because the majority of people don't get rotator cuff tears. So this is a picture of a rotator cuff tear. Before I showed you that video and I said down below is the rotator cuff tendon. It's nice and white. Well, here's that nice white tendon right here, except it's sticking up. It should be attached down to the bone right here. So this is a rotator cuff tear, and then I operate and I sew it back down, and this is what it looks like after it's been sewn down. It looks like a normal tendon, except it has these stitches in it. That's how we repair it. We just sew it back down, and then you hope it heals. So this is an MRI. This is the best imaging study that I have to look at the shoulder. This is a normal left shoulder, so we're looking right at somebody's shoulder. The head is up in this direction here. You can kind of get a little bit of the curve of the shoulder right down here. This is our little friend, the acromion, that bone up above, which can dig into the tendon. And this structure right here is the supraspinatus tendon. And that tendon, I'll take that away, that tendon is still attached to the bone. Okay? It is not detached. You can follow it all the way to the top of the humeral head. And because the rotator cuff muscle in this case is intact, when the deltoid tries to pull the arm up, the rotator cuff sucks it into the joint and keeps the ball centered on the joint. And because the ball is centered on the joint, there's still nice space between the bones. And oftentimes we refer to this nice little arch that forms down here in the bottom as nice and maintained. In somebody with a rotator cuff tear, this is where the tendon is. And that tendon should be attached way over there. And now the rotator cuff is not working, so when the deltoid tries to lift the arm up, the whole arm comes up. That little arch in the bottom is broken, and the humerus now comes up so it starts rubbing against the acromion, and that causes a lot of pain. So the deltoid is the big bully, but it's important. And what happens is that for us human beings, the rotator cuff tendons are small muscles with poor blood supply. They're very important for the mechanics of the shoulder, but they're commonly injured. So this is a video of what we do with a rotator cuff tear. I'm not showing you physical, if you have a rotator cuff tear, physical therapy is not going to fix the problem. A cortisone injection is not going to fix the problem. It can make you better. And I have many patients who have rotator cuff tears who say they don't want to have surgery, and I say that's fine. But I also tell them that they're not going to end up with normal shoulders, depending on the size of the tear. Sometimes with a small tear, I'll treat them non-operatively. But a big tear like this is probably not going to get better on its own. So that's the tear. The tendon's torn off the bone. First thing I often do is get rid of the bursa and then get rid of the bone spur up on top. I don't want that bone spur persisting after the repair and digging into my newly repaired tendon. We put anchors into the bone, and I'll show you a little bit later how we do that. This is a titanium anchor, which I sometimes use, but mostly I will use either a bioabsorbable or a plastic anchor. The anchors are like little harpoons that go into the bone, and then there's suture material coming out of the anchor. And I'll use a little device that pierces through the tendon and grabs the suture. And I put in a couple of anchors and I pass the sutures, and then I can grab the sutures and tie them. And once I tie the knots down, it will suck the tendon right down onto the bone. Drill a little hole in the bone, we can put one of the anchors in. And the final topic to talk about is arthritis. And arthritis comes in two variants. It comes with and without a rotator cuff tear. what arthritis is not a ligament problem, it's not a muscle problem, it's not a bone problem, it's a cartilage problem. And that's our nice normal video on the left. And this is an example of an arthritic shoulder on the right. And notice the difference of the cartilage that's on the ball and the socket. The one on the right, the cartilage is peeling off the humeral head. And you're down to bare bone. And that's arthritis. So when people say, can't you just go in there and clean up my arthritis? Arthritis is the loss of cartilage. You can go in there and you can clean up the debris and the loose pieces of cartilage. I use the analogy of paint that's peeling off the wall. I can sandpaper the wall, but I can't repaint it. We don't have that technology. There are some academic centers that are experimenting and putting in allografts and trying to grow cartilage in 20-year-olds who have arthritis, but nobody has a wonderful cure for arthritis yet. So I just thought this was a nice video showing you a normal shoulder on the left with normal smooth cartilage on the ball and socket, and a video on the right showing the cartilage is peeling off and you're down to bare bone. And that's what arthritis is. It's the loss of cartilage, and that's why there's no great cure for it, because we don't have the ability to repaint or put new cartilage down. So this is an example of a normal shoulder on the left and an arthritic shoulder on the right. In a normal shoulder, there is a space between the bones. That space is filled with that cartilage. The x-rays only show us the bone. They don't show us the cartilage. Even in a normal shoulder, you can see the AC joint has a space on the left, but on the right, it doesn't show up well here. There's no space. The bones are rubbing against each other. That's the definition of arthritis. And the way to treat this is stay flexible, take your anti-inflammatories, cortisone injections, same as before. I don't find strengthening very helpful in arthritis, because when you're bone on bone, I find that when you do any type of strengthening, it can just grind the bones together. So I find the most effective therapy in an arthritic shoulder is the flexibility exercises, to try to decrease the joint reactive forces to prevent that bone from rubbing against each other. When all that fails, when people have persistent pain, don't want to live with it, want to get better, then we do a shoulder replacement. And that's what it looks like before, and that's what it looks like afterwards. It's a plastic socket with a metal ball. And so the space that's now there between the ball and socket is filled with plastic. So because you're no longer bone on bone, the pain goes away. What do you do when you have arthritis and a rotator cuff tear? Well, from what I've told you guys should be a little bit suspicious that something's not normal with the shoulder. The humeral head here is way up compared to the socket. This little arch right here is broken. And this is a picture of a large rotator cuff tear and arthritis. It's bone on bone. If we try to treat this with a regular shoulder replacement like this, the way people do, it doesn't work. People have persistent pain because the humeral head is way up here. The rotator cuff is not keeping it centered on the socket. And you get loosening of the socket. So in this situation, when you have arthritis and a rotator cuff tear, we have to treat you differently. Here's the final kind of educational slide before I show you some fun things. This is, arthritis. You have an irregular flattened joint right here. You have a nice maintenance of the joint space. The ball is centered on the socket. We have a nice space up here. So this is arthritis with a normal rotator cuff. We do a regular rotator cuff repair. Here we have arthritis, very little joint space. The humeral head is articulating against the acromion. That's where our supraspinatus is supposed to be. We know the humerus is elevated. This is a rotator cuff tear with arthritis. We can't treat them the same way, so this is where we use a reverse shoulder replacement. And that's what a reverse shoulder replacement looks like. And as its name says, we reverse. We put the ball on the socket side and we put the socket on the ball side. And by doing this, we have pushed the arm down and we have prevented the arm from rubbing against the acromion. The reverse is a completely non-anatomic solution we have for a difficult problem. So I never tell people they have full range of motion. But I'm about to show you examples of some patients that were happy with what they had done. This gentleman had bilateral shoulder replacements. He's different than the first picture I showed. Not every one of my patients does as well as this. But this just shows that this is what can be accomplished with shoulder replacements. Here's a gentleman, young gentleman. Now he has bad pain. He has arthritis and a rotator cuff tear. He also has a little bit of peripheral neuropathy, so you'll see that later in this video where he kind of stumbles. So that's before I do a reverse shoulder replacement. Now this is what happens after. So I try my best to tell people that I can offer pain relief. And when I talk about pain relief, I'm talking about pain that's maybe an 8 on a scale of 0 to 10, down to maybe a 2. But it's rare for me to make somebody a 0. And when I say that when your pain improves, your function usually improves. I mean, if before surgery they're like, that hurts, I'm hoping they can say, hey, doc, look what I can do. But it's rare for them to get like that first guy. And here's a lady who had a reverse shoulder replacement on her right side for arthritis and a rotator cuff tear, and a regular shoulder replacement on her left side. Now, I do find that pain relief can be equally effective in young patients like this lady, who's, I think, in her 50s, and patients in their 70s and 80s. They can both say, boy, my shoulder feels a whole lot better. But I do find that functional improvements is greater in the younger patients, and I think that has to do with the fact that their muscles are still somewhat healthy and robust. Thank you very much, and if you want any further information, you can go to seacoastshoulder.com or www.smao.org.